Thank you very much. I'm very honoured to be here. It is my first visit to Kuwait, and already within the first hour of being here, I've come across two great friends. So I feel very welcomed, and really would like to acknowledge the honour that I have been given in being able to talk. Minor problem, my slides aren't here. So I have to say that thank you very much to the first two speakers, because you've cut my talk dramatically already. And I'll have to call on my husband in the front row to put my slides onto a PowerPoint, I think, a USB stick, and find them.
I think it's, maybe we can have 5 minutes or so for questions. Sure. For Professor Abdurrahman and Professor Scott. I was planning to keep the questions for later. So it's a good chance now to take a couple of questions.
I lost my USB stick.
Go ahead, Dr. Saad, microphone,
Roger,
please.
Just we are considering there is much lack between, or not matching between the competencies we need the nurse or the doctor or pharmacist to practice and what they've been taught in their curriculum. Can you put this in your, because I saw your curriculum is
Yeah. Well, your question is about the mismatch between what the learners or students in all professions, but you mentioned an example of the nurses, is something different than the reality or the practice. This one, of course, I mean, we observe this, but we need evidence about this. But let me give you an example of the issue of curricula. The issue of curricula is mainly how to implement what we planned to be, which is the written curriculum. I mean, if you wrote the curriculum with a very nice way that cover everything, all the things that you want, and specifically the outcomes, the learning outcomes that you expect out of this program, your students to be competent enough. The problem is in the implementation, because the exposure of the staff who run this curricula is not similar. And we observe this from different health colleges. The faculty members, they came from different background. They need a good preparation, faculty development program. And I listed this. One of the problems is the faculty development programs. We have to train them well. The other thing is the way how can we monitor the outcomes of this program. The only way we monitor this from independent way is from the Saudi, like in Saudi Arabia, Saudi Council. They have the SLE examination, and they examine all the graduates of health colleges to see whether they are capable for continuing their further education and residency. And same thing, I think, in North America, the UCMLE examination and other countries. But we don't know whether these competencies that we measure or we assess are fit with the curricula that the schools they blend with. So I agree with Vic from observation, but we need evidence from literature.
Thank you, Professor Abdurrahman. Sarah, we can go on.
So I certainly would like to restate or reinforce the take-home message from Professor Abdurrahman and also from Professor Marie Scott about the leadership issues. And I'm talking about interprofessional collaborative practice. I'm going to zoom through a few slides here, and in a nutshell, I'm going to tell you that mine was a wicked career path, I've decided, since I I trained in the UK, worked in Canada, went to Australia, went back to Canada, went back to Australia, and come to you today, although from Australia, I'm actually working in Canada. So if you can get around all of that, we'll just bypass all these slides. The key difference where I was working in Australia and where I'm now working in Canada is that in Australia I was in Darwin at plus 30 every single day at least, and in Canada minus 30 many days. It often looks like this, and I think something to really be aware of is that they actually completely clear the roads so that you are just driving on tarmac. But many of the times it's like this, and it can be hell. I'll come back to that if we have time. So, interprofessional collaborative practice, to me, really is about the whole is greater than the sum of the parts. And as our first speaker was saying, that interprofessional practice and interprofessional education really go hand in glove. So I'd particularly like to mention Leslie Bainbridge from the University of British Columbia, who not only helped me in understanding the Canadian competency framework that's been developed, but also lent me some of her slides, which unabashedly I use. So I will go through the framework, show you how I've applied it to my situation, and if we have time, we'll talk a little bit about getting the I back into the team, where the I is the individual taking on the responsibility that was referred to by Dr. Scott, Professor Scott, sorry. So the sum of the whole being more than the sum of the parts, I think really is summed up in D here, that you're, as an interprofessional team, you're working together and you go and find solutions that go well beyond your own vision of what is possible. And the key difference between an interprofessional team and just health professionals working together, as our first speaker said, is around three things. Leadership of the team, performance appraisal, and often this is between health professionals from different backgrounds, and the other thing really is about reflective practice. If it's yourself, it's really reflective, and if it's with the team, it's reflexivity. And these are the key differences between, as I say, just a working group of multi-professionals and an interprofessional team at full performance. Now, in 2008, the Canadian government put $800 million, 2002, the Canadian government put $800 million into interprofessional initiatives in both interprofessional education and interprofessional practice. However, between 2008 to 2010, that money disappeared and wasn't reinvented. However, in 2008, the Canadian government did sponsor developing a national interprofessional competency framework. It's centred on 6 competency domains, and I particularly like this one. Having worked in all these different countries, I've looked at a lot, in part because it refers to that conflict resolution that Professor Scott was talking about, and the importance that we need to be able to work together. So this is an example of one of the domains. So each domain has a competency statement, and the competency statement is expected to withstand time, whereas each statement then has descriptors, and the expectation is that these descriptors will change over time. This is what the competency framework looks like. I hope hope you can see it better than I can from down here looking up there, but what you'll notice is that obviously the goal in the middle is interprofessional collaboration with 4 of the domains around it, and then 2 of the domains, the patient, client, community-centered care, and also the interprofessional communication domain, are in the 2 ellipses around that central circle. And that is because these 2 domains in particular have more influence on all of the other domains. However, in the background you can also see that there's quality improvement, contextual issues, and the the degree of the problem, I'll now call, going from simple through complicated to complex, and those wicked problems of Professor Scott's. So each domain has the characteristic that comes from French social work of complexity, which reflects the dynamic organisation of the team, the additive aspect that it will build on what has been already known before, both from an individual perspective plus the team knowledge, integrated because of all the variety of resources that will be used, developmental because we believe that this will expand over time, and evolutionary because you're creating new according to the given context. So very quickly, some examples of application of a competency or other type of framework is useful when you can use it for all these settings. So I'll rapidly say that this is the one for capacity building and strategic planning. It's the same framework, but just been reorganized. And I have used this in our own hospital in terms of capacity building and trying to find out what interprofessional practice actually looks like in our hospital, and I'll go through that in a minute. This is another version that outlines the online modules that have been developed by UBC, which reflects the Canadian Interprofessional Competency Framework. And the benefit of this is that whereas the interprofessional health practitioners say that they have the skills, they often need the first steps. And this online module will be available later this year. Having a framework allows you to assess. It gives you a common language, and then you can assess whether it's the self-assessment or the team assessment. And so this is where I work now. This is the Health Science Centre, one of the networks for the Northern Ontario School of Medicine, which you'll hear more about tomorrow. And I was given the charge of finding out, as I said, what does interprofessional practice look like in our hospital. And with such a title of Associate Vice President, Academics and Interprofessional Practice, it gave me an opportunity to go wherever I felt like roaming, and probably opened a few doors that would have liked to have been kept shut. But as was discussed before, the whole issue is that we need to discuss what's not working as well as what is. So with one size not fitting all, I found that the best interprofessional teams, in the true sense of the word, where they are covering comprehensive patient issues and on a consistent basis, seem almost to be naturally occurring in rural practice, palliative care, cancer care, stroke care, and care of the elderly. And I'll just give the example of the coach team. So the coach team started up as a research exercise in the emergency department to assess the elderly, so that within 48 hours of admission, they would have 5 functionalities assessed. And this is just the picture of the team. They meet every day, they share their responsibilities, they set each other up for handing over care and bringing people in that are needed. So that, and here are the 5 functions that they assess, and this is just for the over 65s. So when I look at this coach team, I find that they're really at the top of their level. They've been going for about 18 months, and they're dealing with very complex problems of the elderly, and are very interdependent as well as being able to work independently. They each know what the others can do, and they prepare each other, as I said, for any referral. We have pockets of care and education and training happening with intermittent interprofessional teams, such as operating theatre, but on the other hand, if you go to the orthopaedics operating theatre, you might find them excellent in theatre, but out in outpatients, I'm told by physio, they never talk to us. So that doesn't come across as a comprehensive interprofessional team. However, there are other little areas such as the virtual intensive care unit that has been set up based on the principles of telehealth. And this is just a bit of a reflection of how the virtual unit works. And they did a pilot, a prototype, to check that it was going to work. And what they found was that basically by reducing some of the referrals into ICU, by providing the support virtually through telehealth to the teams out in the smaller hospitals, that they, for each transfer, they reduced the cost by $10,000 and more. They have certainly built up the skills in the smaller hospitals to reduce the referrals coming, as well as actually helping on a needs basis. So here, the virtual ICU team, they've only been going for a few months, and so and yet the clinicians are all very expert. They have a pharmacist, a dietitian, social worker, OT or rehab, plus the telehealth coordinator and the ICU intensivist. This is just we have a wonderful simulation lab, and they run an anaesthetic boot camp, which they try to run as an interprofessional practice. However, it still tends to be within a discipline. So these, in fact, are just doctors talking to each other, and what we're trying to do now is move them so that they actually bring in a team with all the health professionals involved, including the ward clerk and the cleaners and everyone who has any involvement with the patient and is valued by the patient, to actually train rather than just sticking to a discipline. I'd also like to suggest that it's beyond clinical care, so that we have quality improvement, patient safety, which is known to benefit from interprofessional teamwork, but also healthcare management, and specifically the allocation of resources and senior management support. So our hospital is going through organisational excellence training. They're using the lean process for a quality improvement hospital-wide. And quite frankly, they haven't, they're really struggling. They're doing a lot of just the simple problems to start with, but they don't have patient engagement, they don't have physician engagement. And there's a lot of work in learning about the lean process that needs to go on before they're actually going to be successful. That's internal to the hospital. Externally to the hospital, we also have the problem that the Ontario government are bringing in quality-based funding for quality-based procedures. And this, rather than being a nice little guidebook, is actually 90 pages long. And our problem here really is that there are 4 main hospitals in our area who will do total hip replacements, and therefore can be expected to pick up the hip fractures. And yet these 4 hospitals are expected to influence the way the smaller hospitals, of which there are 21, to be able to get their funding. So this is what I call ripe for disaster, because as was said earlier, you have to control. It's the circles of influence and where you have control. So it has to be made within the smaller hospital interests to be able to align with the regional hospital to be able to then get the regional hospital to get their funding. So there's going to be a lot of work on that. And currently we have communication trees of teleconferences happening with a minimum of 30 people on a teleconference at one time. And you can imagine what that's like.
Sarah?
Okay.
You can wrap up, please.
And this is how I have assessed that team. So I think that the interesting thing is that what I'm referring to is that there's a high risk of the team not working. And Scott Reeves has developed a framework for all these interprofessional relationships, and within each of these, there's a further 4 dot points of team behaviour. So it is a very complex process, but as our first speaker said, the most important thing is actually to get a better understanding, to be able to convey it to the politicians, to then get funding that is consistent and continuous, and not the chop and change process that we've had in Canada. And it will be through making sure that we get all these things together. This is where we put the interprofessional work integrated and interdependent as well as independent. So I'll leave it at that, and thank you very much.
Thank you very much.